as Sarah's parent. How would you feel if you were in this situation?
Extremely frustrated because there really isn't anything the parent can do. It's likely in some situations that the parent doesn't even know that all this is going on and doesn't know until there's some kind of crisis. But assuming that I know that my daughter has a problem, there's nothing I can do except call and at least talk to all of the folks involved so that I know that they know that I'm concerned about what's going on. And then I'd hope that maybe one of Sarah's friends would call me. Again, that's really breaking confidentiality in terms of the friendship code. But I'd hope that one of her friends would call. And if I could, I'd go and just sit in somebody's doorstep until somebody told me something.
How can you as a parent work with the university in this situation?
Like I said, I think the only thing that I could do is make sure that I'm in contact with Diane, since we keep on bringing up her name, and Juanita and any of the other people who I know are involved. The professor, just contact all of them and make sure that they know that I'm supportive, that I'm concerned, that our family has been working and trying to do everything we can on our end to help Sarah so that if there's a point where they do think that maybe she'll sign a release, they'll feel comfortable that she'll sign, that she'll sign a release, and keep those lines of communication open, understanding they're not going to tell me anything. There's just going to be me doing the talking.
Are you not worried that Dr. Martin's going to accuse you of being a helicopter parent?
She just might, but at this point, if I'm concerned about whether or not my daughter is going to take her life, that's a chance I'll take. And hopefully, as much as she can, she'll even give me some guidelines about how I can more effectively work with my daughter and express my concerns to her. But at that point, if I think that my daughter's going to take her life, I'm going to do everything I can.
If I had you as a mother, I'd be president of the United States. The situation worsens. Sarah stops going to the counseling center to see Dr. Martin. She no longer keeps her appointments. One evening, Stephen, the esteemed RA, goes in to check on her, and he interrupts her as she's about to ingest an entire bottle of Tylenol. He decides to take her to the local psychiatric emergency facility, where she is seen by a community health provider. How can the community psychiatric emergency facility work with the local community mental health system to provide immediate care?
Well, one of the first and most important aspects of, let's say Sarah comes in with a good friend, that we are able to provide an environment, unlike a ER hospital, to have an environment which is a 24/7 access type of assessment or evaluation for behavioral health. So the student and her friend are not sitting in a good hospital, but a hospital designed in ER for a whole variety of different other conditions. And hopefully we get the person available and open in this 24/7 access service to be able to have them comfortably go through an evaluation that is effective and responsible.
Okay, now let's assuming you've done the thorough evaluation, as the Coleman organization is wont to do.
Absolutely.
How can the local community mental health work with the University Counseling Center? Because you ain't going to keep this kid here forever.
Yeah, right.
So what are you going to do?
In ideal worlds, what we want to do is provide an access service regardless of the ability to pay. And in our process of, in this example with Sarah, whether she needs short-term hospitalization, work with the facility with 24/7, work with the facility that she might need short-term psychiatric beds. And the key to that, whether it's the school counseling service or the hospital, we need to keep communicating on a consistent basis on Sarah's behalf of the problem. This is not often billable units. Many times the mental health organization doesn't get paid for it, but they do need, and that's a high priority, to communicate these issues about Sarah and in support of Sarah as she might go to one environment from another. after responsibly getting an assessment. So in the ideal cases, at Kent State University's example, we happen to have a psychiatrist that works for both providers. This is ideal, but in this situation, there is an open psychiatrist that gets to talk about the case in Sarah's idea and says, okay, well, I know this other doctor, and this other doctor I've talked to about your case. I want you to see this doctor immediately. Again, with the counseling service, if we have a common doctor, or if at least the doctors are talking, maybe it's not the same common doctor, we're talking about those issues with proper release. We're making it seamless as the student has to go from one environment to another environment. We're doing very responsible follow-ups with appointments as already made, immediate appointments, no waiting time, and also a 24/7 access in case things get bad at 3 o'clock in the morning. So if the person is released, if Sarah is released back to the college dorm, we want to have a lot of follow-up and catches, discharges, working with the counseling service. Did she get an appointment with the counseling service? Did she get an appointment with the community mental health organization? Did she no-show? What's the ramifications of the no-show within a very, very short time? Do community mental health organizations have protocol? If Sarah no-shows the next day with the appointment, what do? Do we just call 1 or 2 times and leave a voicemail? Or do we actually follow up in a variety of different support systems to make sure that Sarah's safe?
I like the word seamless. I like the work that you've been describing about the necessity for a collaborative relationship, a collaborative working relationship with your facility and the university. It sounds like if you ain't got it, the kids are going to get fallen in the crack, aren't they?
And it happens, even with good services, whether it's Akron, Portage, Trumbull, in any county, because we have these still silos of service, and we have to break the silos down because Sarah comes first, the family comes first, and the professionals need to work together, whether it's the hospital, a professional hospital, or a professional private practice even.
It was mentioned earlier when someone mentioned the VA Tech. You see, one of the big mistakes at Virginia Tech was this, that the people in the Community Mental Health Center didn't talk to the university because they thought that what they were doing would be a breach of confidentiality, so nobody at the university knew about what was happening with respect to CHO's treatment. And that was a very critical issue in the VA Tech problem. So when we talk, for example, not to put a plug for my book again, but the chapter really talks about how you can use the community mental health model for establishing the kind of care for the college community. Mm-hmm. And you've just demonstrated that very nicely. At what point, if any, would you contact Sarah's parents?
Well, we would use actually the same process that Juanita had covered. We might talk to Juanita to see if she has a release yet, and we would work in that relationship, if the relationship was sound, to try to get her working with the parent or getting released with the parent. One thing that I think in most community mental health organizations are doing better these days is even with the release or with the approach of a release, get the parent involved. If the parent is, as was described just a minute ago, hovering in the waiting rooms, demanding to talk to the doctor. There are great doctors now that take the time and talk to the parent without a release. They don't say confidential information, but they even take the time, a non-billable unit time, to talk to the parent and discuss the issues of their fear and their hurt and their despondency about their daughter or their son. And that's the kind of psychiatrists we need more of, but we have a lot in this area.